All right. We'll get started today. Thank you, everyone, for coming. And I'm Ken Mandel from the Computational Health Informatics Program at Boston Children's Hospital. I'm a professor of pediatrics and biomedical informatics at Harvard Medical School. And I will share my screen and get us started. So today's CHIP Landmark Idea Series is Enduring Stigma, Historical Perspectives on Disease Meanings and Their Impacts. And I'm really, really pleased to have here today a mentor and an extremely longtime colleague, Allan Brandt, who's a leading historian of medicine and science and a professor at Harvard University. The Computational Health Informatics Program, where we host the Landmark Idea Series, is founded in 1994. We're a multidisciplinary applied research and education program, and you can learn more about us at chip.org. This event series includes thought leaders across healthcare, informatics, IT, big science, innovation, and more. If you want to follow along or tweet, here's a couple of Twitter accounts to make note of. I'll briefly introduce Allan. Allan will give his presentation. Please put your questions in the Zoom Q&A box as we go. You can start right away with those questions while you think of them, and we will get to them. And then I'll have some brief closing remarks. So before I introduce Allan, I just want to put up a paper that one of the most enjoyable experiences I've had actually in my academic career was writing really my first informatics paper with Allan. And this was on electronic patient-physician communication at a moment when in society, it was really felt that this would be an extremely dangerous and fraught venture to put doctors and patients in email contact. It would overwhelm the doctors, that patients having heart attacks would email their doctors in the middle of the heart attack and then wait around for a response. And many things that happened, many things that people were concerned about that didn't ultimately prove true when these systems were deployed. And as a result of this paper, we actually took the informatics forward and created the first secure doctor-patient electronic communication tool. And it was amazing working with Allan because as a historian, he already could see into the future, I think, looking backward, where we have at this moment, where we can see that indeed we took this kind of historical perspective in the present at the mistakes people were making at that moment in conceptualizing this new field and documenting them. And so that kind of thinking, I hope we'll get a flavor for in Allan's talk today. This little graphic was this cheesy early web graphic was like a special experimental thing for our informatics paper, something that Annals of Internal Medicine really probably hadn't published things in the informatics space very much before. And so this is what they added in, which was very sexy at the time. So Allan is the Amalie Moses Kass Professor of the History of Medicine and Professor of History of Science at Harvard University. He's the author of No Magic Bullet, A Social History of Venereal Disease in the United States since 1880, and the co-editor of Morality and Health. He's written on the social history of epidemic disease, the history of public health and health policy, and the history of human experimentation, among other topics. His book on the social and cultural history of cigarette smoking in the US, The Cigarette Century, The Rise, Fall, and Deadly Persistence of the Product That Defined America, was published by Basic Books in 2007. The book received the Bancroft Prize from Columbia University, the Welch Medal from the American Association for the History of Medicine in 2011. Not surprisingly, he's been elected to the appropriate high honorific societies. He's currently writing about the impact stigma has on patients and health outcomes, and we're going to hear about that today. So I will stop sharing and turn it over from here to Allan.
Thanks so much, Ken. It's really fantastic to see you. As Ken mentioned, we wrote this very early paper together on medical email, and really it was Ken who was the lightning of ideas behind that paper. And long before any of us were really using electronic communications with our caregivers, Ken had really thought through the opportunities that would dramatically enhance our ability to know and understand healthcare that we're receiving. And this morning, I was on my MGB portal communicating with one of my clinicians, and it's become so deeply penetrated and embedded in the way many of us are able to think about our care today. And I credit Ken with seeing into the future while I was looking at the past. So it's wonderful to be here, and I'm so grateful for your invitation to speak to this group. As Ken mentioned, I'm working on a project on the history of stigmatized diseases, and I'd like to walk you through at least where I am now. This is work in progress, but it may be somewhat unusual to be thinking about these kinds of things right now in a group that's been so committed to working on issues of AI, machine learning, the opportunities of the digital revolution for medicine. But I hope by the time I get to the end, some of you will have some ideas for me about how I might think through what some of the opportunities are for understanding the character of these types of diseases. So let me just start by saying that I've been thinking about stigma really throughout my career as one of the principal problems that makes it so difficult for us to approach problems of disease, one of the major obstacles to the care and treatment of individuals. And very early in my career, I'd written about HIV disease, and I began to understand the role that stigma played in the pandemic for patients, for population health care. So the basic definition of stigma, this is from the Oxford English Dictionary, is that it's a mark made upon the skin by burning a hot iron. It has deep implications from the history of Christianity, that it's a mark of disgrace or infamy, that these marks resemble the wounds of the crucified body of Christ. And this has had this is kind of the basis, but studies of stigma really picked up beginning in the 1960s. And I'm not sure how many of you may have read the original book that kind of created massive attention to stigma by a brilliant 20th century ethnographic sociologist, Irving Goffman. And Goffman really looked at stigma in a way through the eyes of an anthropologist or ethnographer. He said that stigmas were associated with what he called abominations of the body, of blemishes of character, of tribal hatreds, but that these factors would dramatically lead to the isolation of people who carried a stigma. He saw stigma largely as a fixed condition. And then what he really wanted to study was how did people who had a stigmatized identity, whether they were disabled, whether they were felons, whether they had a particular disease that seemed to incriminate their character. How did they manage to try to hide or deflect the social hostility that their stigmas contained? The second author that had a tremendous influence on me is probably better known to many of you, Susan Sontag, the great literary critic of the late 20th century. And in the 1970s, Sontag wrote about two diseases and the attitudes and values associated with them: tuberculosis, which she centered on in looking at opera and literature and the character of people with consumption, versus ideas in the mid to late 20th century about cancer. And at the time Sontag was writing, she was experiencing breast cancer and its treatment, and she felt highly stigmatized. Some of the theories of cancer at that time said that cancer really is generated by repressed emotion, hostility to the body, not being adequately expressive. And she took this quite personally. At the time, she did not reveal that she was suffering from cancer when she wrote so much about it. She followed up illness metaphor in the early decade of the AIDS pandemic, finding many similarities. And I have tremendous respect for this work. It's gigantically influential on literary theorists, social scientists. But in each instance, my own observation of cancer has led me to at least refine or revise, if not be openly critical of their perspectives. And I'll tell you what two of those ideas are. One is Goffman saw stigma as an absolutely fixed status, and it never changed. And how did people being in a stigmatized body try to persist and show resilience? Sontag really felt that if we could effectively treat all diseases, that we could end the stigmas that are associated with them. And as you'll see in a minute, I'll take issues with both of those views.
Allan, at this moment, as you're transitioning slides, I just wanted to give you the opportunity to switch to the projection mode from the presenter mode, if you'd like to.
Yeah, let me do that. And maybe I thought I was going to be able to do that. And do I have to do?
That might work. Yeah.
Did that do it?
You got it.
Awesome. Okay. Thanks so much, Ken.
Sure.
What I want to say is that we often think of stigma as literary or as a metaphor, as a social aspect. But one of the things that I've tried to do in the work that I'm doing now is to emphasize that stigma really has material impacts on the course of disease and its treatment. And we use the term biosocial quite a lot in the field of social medicine, medical anthropology, history of medicine. But there are powerful biological impacts of suffering a stigma, and stigma as a social force has powerful biological characteristics in how it affects the body. Stigma augments health disparities. It leads to isolation, stereotyping, and alienation, and a variety of other mental health problems and symptoms. It creates a major obstacle to health seeking and access to care. It has an enormous economic impact on healthcare costs and social costs. Very often people don't get treated early enough or adequately because of the particular stigmatized disease that they are diagnosed with. I don't have really clear figures on the economic impact across a number of these diseases, but that's the kind of thing that would be really helpful to be able to generate. They're what I call iatrogenic stigmas. that are reinforced within medicine. I'll only have a chance to say a bit about obesity, for example, but in studies of medical school admissions, it's been shown again and again that individuals who are overweight often are discriminated against in admissions, and there are many ethnographies of clinician-patient interactions around issues of weight that actually are incredibly alienating and often lead to patients leaving care. And I'm interested in a kind of social epidemiology of stigma and its impacts. I just mentioned this, but many people have now pointed out to issues of what we might call the embodiment or the physiological impacts of being stigmatized. And this literature has grown significantly over time. So what I really want to get to is this idea that stigma is not a fixed condition, but that it is historically and culturally variable, and that there are forces which encourage the development and the persistence of stigma, but also potential strategies for undoing it. And all of you know there's a lot of literature emerging on strategies for destigmatization, but we actually, I think, are at a very early phase in being able to understand what works, why it works. And my project tries to center attention on many of those issues. And so I've sort of tried to take a historical approach. Are there stigmas that we could trace that have grown and stigmas that have decreased, and why? And in many areas of this study, I'm sort of focused on the history of HIV and AIDS, which I lived through and observed closely as a historian. And I think everyone knows, even if they're considerably younger and didn't live through the AIDS pandemic, that when AIDS was first identified in the early 1980s, it set off what sociologists often call a moral panic. And there was persistent hostility, agitation, protest, with the idea that people had behaved badly through their gay sexuality, and as a result, got a disease that they essentially deserved, and that there was no role for the state, for public health, really for medicine to address this because of its intense stigmatization and the aggression that AIDS unleashed. And this is characteristic of these kinds of views. There were many views in the evangelical community. Why should we pay any attention to this at all? As many of you know, Ronald Reagan didn't even mention the word AIDS for really until the very last year of his presidency. And this very idea that, there was no social role here. And, quite frankly, many physicians expressed these types of views. There was a well-known orthopedic surgeon at UCSF named Lorraine Day, and she just said, I'm not treating gay men in my surgical practice because it creates too much risk for me, and that physicians had a right to opt out. All things that in many ways contradict our norms about medical ethics and responsibility to patients. But it wasn't only in the right-wing media and protest where we could see these kinds of stigmatizing views. This was an article that appeared in the New York Times Magazine in early February 1983. In fact, exactly 40 years ago this week. And it was written by a well-known and very highly regarded science journalist, Robin Morantz Hennig. And I had been working for some time on issues of gonorrhea and syphilis. And there was this notion of what was called syphilis of the innocent, disease that a man who may have visited a sex worker would come home and infect his wife. Soon they would have a child, and the child would have congenital syphilis. And the idea was that this was innocent syphilis. And as I was reading Morantz Hennig's essay in the Times in 1983, I saw it said the groups most recently found to be at risk for AIDS present a particularly poignant problem. Innocent bystanders caught in the path of a new disease, they can make no behavioral decisions to minimize their risk. Hemophiliacs cannot stop taking blood clotting medication. Surgery patients cannot stop getting transfusions. Women cannot control the drug habits of their mates. Babies cannot choose their mothers. And as I thought about this, Hennig had created this notion that there were innocent bystanders who had been infected with HIV, and that they were somehow different than the gay men who were the dominant risk group in the pandemic. And I had a chance some years later to talk to Hennig about this. And I think not surprisingly, she said, well, I had no intention of implicating gay men, but I was trying to make this point that there were these behavioral aspects and that there were many people who were not responsible. But once you get into the notion that some people who suffer from a disease are innocent, then you make those who communicate it really guilty perpetrators. And we've seen some aspect of this way of thinking, even most recently in the COVID pandemic. Who did you get it from? Were they responsible? Had they taken appropriate precautions? And victim blaming, you weren't careful enough. And these are elements of what I'm calling the process of creating stigma. But this is very interesting to me because at that time that I was originally observing HIV, if anyone had asked me, what's the future course for gay people, for stigmatizing disease, I thought we were entering a really incredibly difficult, problematic, hyperbolic moral categorization of patients. But 35 years after Hennig wrote, the Supreme Court approved marriage equality. And I thought on that day, this photograph of James Obergefell, who was the principal litigant in the case, and the steps of the Supreme Court in June of 2015, I thought, well, things had really changed at least somewhat. And it's not that I want to argue that there isn't stigmatization of AIDS or people who are gay, but that social tolerance had changed, the nature of gay culture and its acceptance in our lives and our institutions had fundamentally changed from the early HIV epidemic. And I had posited that HIV would lead to devastating discrimination and stigma around people who were at risk, especially gay men. And so I started thinking, how do we account for the kind of change that we saw around HIV, around gay rights, around marriage equality? And this has been central to the problem that I'm trying to investigate now. And early in the pandemic, I was giving a talk early in the AIDS pandemic about HIV and and I used the term AIDS victim, and this young man stood up in the front row and really shouting said, "We don't consider ourselves victims. We consider ourselves people with AIDS." And he was one of the authors of a very important declaration very early in the epidemic, where he said, "We condemn attempts to label us as victims," a term which implies passivity. We are only occasional patients. We're not helpless, and we don't, and our dependence upon the care of others is, part of our disease. We are people with AIDS. And I was shocked at the time. I was young, pretty immature, young academic. But this man, Michael Callan, expressed something very important about the disease not becoming one's identity. And this was characteristic of problems of stigma. Some of you have seen the film Philadelphia. Callan was a musician, and his band has a short cameo at the end of the Jonathan Demme film starring Tom Hanks, and Callan died a year after the film was made. There was debates about AIDS, about whether they should be in death certificates, about whether an obituary should include that someone died of HIV. Many of us who lived through that time remember the numbers of people young men especially, who died very young, and it would say after a short illness, or it would say died of, pneumonia or cancer. And the idea of needing to protect oneself or one's family through these kind of obituaries became the subject of a lot of debate. The question of whether to reveal that one was HIV infected was an issue of incredible sensitivity. There was a debate in the British Medical Journal about whether death certificates should include the data that someone had died of HIV disease. And so I think it just shows the idea that in a way was reflected in Goffman's work about withdrawal, secrecy versus openness. And one of the first cases of a prominent person that became clearly identified was with Rock Hudson. There had been a number of rumors. Hudson had been closeted for his whole career, despite a lot of speculation, but did reveal that he had AIDS. And as a result, it opened up a lot of discussion about these issues of privacy, secrecy, and identity. The other thing that happened that I think is crucial to understanding processes of destigmatization was the emergence of AIDS activism. And I don't think I've ever seen a disease really be destigmatized in some way without there being forms of advocacy and activism. And ACT UP became just a crucial element of this phase of the AIDS epidemic and bringing the problem of AIDS to a group of people who would have isolated, or like Ronald Reagan would mention it, the failure of government response, the slowness of research, that all, I would argue, were an aspect of how highly stigmatized AIDS was in these early years. There was very brilliant communication efforts on the part of activists, and there are a number of design and public relations and communication studies of the work that a small group of AIDS activists did in terms of identifying the stigma and trying to reduce it. this idea of silence equals death is a very effective form of communication. Literally, you could not go anywhere in New York without seeing this plastered on billboards during the early phase of ACT UP. Many of you may remember this, but there developed an AIDS quilt. It was the idea of a gay activist in San Francisco in 1985, where they put together posters. But the AIDS quilt went from city to city. Here it was in Washington, D.C. People walked around the quilts. People met each other. And I think it evoked a sense of solidarity and community among families that had been affected and friends and partners that ultimately had an incredibly powerful effect. The quilt still travels some, but will be part of the new AIDS Memorial Museum in San Francisco that I understand is just about to open. Art had a major impact in addressing stigmas. This is a poster that Keith Haring drew in 1989. And this work continues to have an impact on gay rights and responses to AIDS all this time later. And this kind of political art was incredibly powerful. Haring died the year after this was painted in 1990 at the age of 30. Other art interventions, I think, are very important. There were exhibits of art that emerged during the pandemic. A number of you have probably seen Angels in America, which was just a remarkable, dramatic presentation of AIDS stigma, gay life in crisis during the early 90s. This is a photograph by a well-known gay artist, David Venereal, that he took and was only displayed after he died in 1995. This was thought to be from a Native American hunting process of running buffaloes over the edge of a cliff, but it captured the despair and tragedy for gay men in the early 90s and their feelings about the pandemic. So I think that how did this happen? What does it mean? These have been the principal questions at the heart of what I'm doing. And we know now that AIDS activism was deployed to reduce stigma and demand civil rights, but it had impacts in many other areas. And I think you have to go back farther to understand some of the challenges of that moment. And I've often thought that the removal of the category of homosexuality from the Diagnostic and Statistical Manual of the American Psychiatric Association in the early 1970s and the pre-activism before HIV was incredibly important. One could imagine an HIV epidemic where if homosexuality was identified as a disease, then HIV might have been identified as a disease of the diseased, as many people did. And so this was a critical early intervention. And of course, there are many other examples of containing and reducing stigmas. And I've been really trying to focus in on some of the positive changes with the idea if we could understand them better, then we could potentially utilize some of the insights. This is a photograph from a breast cancer march with these women in their pink shirts, and breast cancer activism evolved in a way utilizing strategies that had been developed by AIDS activists, and vice versa. Both movements had a big influence on each other. And I think for a disease like breast cancer, which I think we could say has been radically reduced in the stigmas that it had in the middle to late 20th century, these are some of the actions that I think we need to understand in a more systematic way. These are two photographs of Betty Ford after she had breast cancer surgery in 1974. And this was just considered radical at the moment, that she would permit herself to be photographed, that it was very clear that she had been treated for breast cancer. And these photos look like from such a different time. And again, I don't want to argue that breast cancer doesn't present important emotional and sometimes discriminatory issues for women who are affected. But cancer is one of those areas that I think we would look to as fundamentally, for many reasons, and many cancers have been widely destigmatized in the last 40 or 50 years. And in obituaries, again, many people did not want to be identified as having died of cancer. And again, there were euphemisms after long illness. And now the fact that somebody has cancer is typically identified in obituaries. And that kind of identification in obituaries is one form of explaining to the world that these are not moral categories or personal failings. The same has been true for disability rights. And in this photograph from 1990, this was a protest on the steps of the Capitol called the Capitol Crawl. And a group of disability activists, about 100, were dropped off in buses at the base of the Capitol and crawled up. At that time, there was absolutely no way for people with disabilities to get into the Capitol building. And here on your right, you see a reference to injustice anywhere is a threat to justice everywhere. This was a wheelchair campaign about accessibility. And I think it's very important to see the connections between the civil rights movement and the disability rights movement. This, everyone knows, is a curb cut. Not everyone has seen this big machinery, but this is a curb cutter. I always think of the Richard Scarry books that I read to my kids when they were very young about identifying machines and vehicles. And I think it's sometimes we miss how we have transformed physical space to be inclusive of people with disabilities, people who use wheelchairs, and that these are profound changes in our culture that have led to at least the reduction of some stigmas. These are prostheses, and I've been observing this. This one is from around World War I on your left. The second one is from World War II. The third one is late 20th, early 21st century. And the premise of having a prosthesis early in the 20th century, nearly to our time, was to try to hide it and to make it look like a limb so that people could hide their disability. And today, we see many people who openly wear their prosthesis. You see people in the supermarket or on the street. And I think that that kind of revelation, exposure, coming out, if you will, has really changed to some degree social attitudes about those who are disabled, and our ability to know and identify and relate to people who were often isolated. Again, I talked briefly about AIDS art. These are two dancers who recently performed at the Whitney, and this is just brilliant dance. They've had ramps designed for their dances, and this is Arlene Shepard on the right, and she's just a remarkable dancer and really a leading figure in what's called CRIP studies, which is like gay studies, a theorist of disability and its social aspects. And they periodically perform in the Boston area. It's really, they are remarkable artists. So one of the questions I'm asking is, what are the implications of these interventions and the chronological aspect of destigmatization that might inform or reduce durable stigmas like mental health, addiction, obesity, and others? And is there a way that we could, in a sense, reverse engineer or draw insights from some of these narratives of stigma, recognition, and reduction for some of the things that have really been extremely difficult to reduce the stigma? Some of you may have watched earlier this week Joe Biden's State of the Union address, and he addressed the fentanyl epidemic that has caused so many overdoses in the United States in the last decade. And one of the congressmen yelled out, "It's their fault." And I just couldn't help but think, why haven't we been able to do more to reduce this notion of blame, responsibility, aggression, and sometimes hatred for people who have these particular diseases? And so I've mentioned some of these, but I sort of put this slide together to kind of review, at least in my own mind, what I think some of the variables are. And I won't read the slide, but as I mentioned, I don't think you get to destigmatization without advocacy and activism. One of the principal strategies is, let's turn this moral category into a disease by medicalizing it. But there are other activists that feel that destigmatization would be served by demedicalizing their conditions. Obviously, effective medical technologies are important, as Sontag would have suggested, but we have so much treatment for so many conditions that are underutilized as a result of stigma and discrimination. So I've been looking at the opioid crisis in this regard as an aspect of what I'm calling durable stigmas. And there are a set of proposals that people are trying to use to think about making opioid use disorder, like other diseases. And you hear, advocates often saying, opioid use disorder is like diabetes. It's a chronic disease that requires management, sometimes relapses, but it really should fit into a disease category, and that we should be using first person language and saying this person is an addict or a junkie. We should stop using terms like drug abuse, because it right away has aspects of agency and responsibility for the individual who's affected. So this is one strategy. The other one I mentioned is medicalization. Drug addiction is a brain disease, and we have therapeutic approaches drugs, counseling, other behavioral interventions, all of which have shown to be, at least to a powerful degree, effective. And so there's a major group that would like to see opioid use disorder and other substance use disorders thought about as in a disease model. But that's been going on for a long time, and it's been difficult to bring that into medicine in a way that would significantly reduce the stigmas. Many people have talked about effective treatments, obviously methadone, buprenorphine. It's been interesting during COVID when some of the restrictions on the use of these treatments, which are specific to opioid use disorders, which in a sense is stigmatizing in and of itself. We often refer to these treatments as medically assisted treatments, and they're medical treatments. So I think that terminology like medically assisted treatment implies, higher levels of responsibility for those who are affected. There's been a lot of discussion during the opioid epidemic about putting an opioid overdose death into an obituary. I have a Ph.D. student who's been studying this and talking to families about how and why they decided to identify a loved one's death with a addiction. And it's a powerful notion. It mirrors aspects of the AIDS epidemic of making these types of diseases part of our communication and recognition in ways that are realistic, sympathetic, and without humiliation or disgrace. We've seen major movements to try to shift opioid use and possession and sales from criminal justice to public health. Again, this is not a new idea, but a critical one in saying this is not a crime, this is a medical condition that we have the tools to care for and to treat. There have been a lot of public media around opioids. Some of you may have seen this documentary on heroin on HBO, and in it, a father of a son who had died as a result of an opioid overdose tells the interviewer, in almost any other case, all of my friends would have been bringing me casseroles, but no one has been here. And it captured the residual aspects of how deeply stigmatized opioid use and overdose death continues to be. Obviously, I've mentioned activism, and I've been fascinated by the activism that has led to many institutions, especially art institutions, removing the Sackler name from their buildings and exhibits. And these are photographs of one of the artists I mentioned around the AIDS activism and artwork, Nan Golden, a brilliant modern photographer, still active. And she developed a group called PAIN that would protest in museums to get them to take the Sackler name off their buildings and to end their ties to the Sackler family, which we know so extensively promoted OxyContin, knowing that it was highly addictive. And she's been enormously successful. The Louvre, the Guggenheim, which this is a photograph of, the Metropolitan Museum of Art have, largely as a result of her activism and the public exposure of the role that Purdue Pharmaceutical played in the overdose epidemic, have removed the name. I've been working with a group of undergraduates in Harvard College who wanted to do more about the opioid epidemic and the overdose tragedy. And so they've written a proposal now to the president of the university, Larry Bacow, and the university recently put in place a denaming process because of concerns about names of buildings that were former slaveholders or other, socially suspect people who are honored by the naming of buildings. And they've written a very persuasive proposal to dename the Sackler museums on the Cambridge campus. And the university has yet to act on this, but I'm personally very hopeful that these students, through an act of advocacy, will get the name of the Sacklers off our buildings. And it's a source of real concern that Harvard still has Sackler buildings, but these great museums and other academic institutions, Tufts removed the Sackler name from their medical school 2 years ago. So I think that this raises a kind of level of consciousness about what are the social origins of the epidemic, and should we be blaming or holding accountable individuals who have suffered and died? Nan Goldin was at Harvard a couple of years ago to protest the Sackler Museum. And, I'm hopeful that the university will respond. It's very interesting. I have this group of students, and they were thinking about ideas that might reduce the stigma of opioids and substance use disorders. And many institutions have now put naloxone, Narcan, in their AED boxes. So my students wrote this really great proposal to the University Health Services, advocating that on all Harvard campuses, we have literally thousands of AED boxes. They would also have naloxone in case there was a unanticipated overdose. And the students went through a lot of different committees, and in the end, the university declined, at least so far, to do this. And I said to them, they've now identified how stigma really works, because why didn't the university want to do this? Well, one of the things they said, well, we don't have a lot of opioid use on campus, but we also don't have a lot of, myocardial infarctions on campus and in the students' dorms and houses. To have an AED box, but not have available naloxone seems to me to be a value-laden moral orientation. And I think the university, quite frankly, was concerned that they didn't want to provide naloxone because it would imply that there was a drug problem at Harvard, even though we know how diverse our campuses are, how many people are students, but how many people are working on our campuses. And it's incredibly diverse populations, many of whom could be at risk for the use of opioids. And I've been very impressed by the students' strategic thinking about how to address these kinds of issues. So I'm going to end here. I hope you have a sense of how I'm thinking about this. I think that stigma is a deeply a deeply unstable category, and that with clearer thinking, with more rigorous research, we can come to understand strategies for reducing it that will assure that people and populations get better, more deeply caring care. I'm going to end with just one last slide. This is Nelson Mandela, with a very well-known AIDS activist in South Africa. And the idea that this activist had Jackie Achmat and Mandela participated in was everyone would wear a T-shirt that says HIV positive, and that everyone, in a sense, would be identified with those who truly are HIV positive. And it's an act of social solidarity, destigmatization, activism. And this T-shirt was widely distributed around the world. And Mandela hadn't done much during his presidency around HIV, but one of his grandsons died of AIDS, and he became, in his post-presidential period, an incredibly powerful advocate for HIV care and treatment, which, as many people know, was not the character of the politics of HIV in South Africa. So I think it's such a hopeful kind of vision of identification with those who are vulnerable, as opposed to the isolation and hostility that so often is directed at individuals who are sick and stigmatized. So I'll end there. I'd like to take some questions and get some good ideas from people who are here about strategies for promoting the notion of reducing stigmas. Thank you very much.
Thank you, Allan. That's so such this double meaning of the word positive, and that HIV positive shirt is really powerful. A powerful message derives from that. Let me ask you a couple of questions. You're reminding me back into about the early HIV era, and something that's a little tangential to the stigma that was clearly an issue from within the medical system, as well as from other vantage points in society. Something new came around, universal precautions. And universal precautions meant that you put on a pair of gloves for all patients when you were doing something that involved needles or fluids and things like that. Before that, what doctors did was decide who needed gloves, which patients you had to put gloves on for. And there was tremendous resistance among the medical community to decide that you don't know who you need to put on gloves for in terms of your infectious disease risk from that patient. Doctors really thought they knew and they could judge. And there's so much wrapped up into that kind of maybe hubris, but also judgment and bias. You know, how you know, were you surprised by that, or did that seem consistent, you know, from the medical establishment's perspective?
It's a really interesting question, because one of the, you know, things that came out of learning about AIDS and AIDS treatment was universal precautions, and just how poorly medicine had managed blood and risk in hospitals, that, you know, we had very high incidence of hepatitis among surgeons and caregivers, which is pretty much gone from the medical world of the risks of caregiving today. And, you know, I've often thought that when we universalize something, then we're not needing to make moral judgments or inferences about patients and who they are and what their experience is. And one of the things we know is that you don't know whether someone's using drugs. You don't know whether somebody is infected. And in a way, the universality of intervention has potentially destigmatizing qualities. And, originally when there were HIV patients in the hospitals in the early 80s, their doors were marked, there was double gowns and everything. And not really in ways that protected anybody, but reflected the fear that HIV generated. There were similar issues, with COVID, and the same thing's been true of medicine, but also dentistry. And, dentists did not wear gloves before HIV, and it's completely nonsensical. And people resisted it. I don't wear gloves. I can't do my procedures well. And, those things have become universal in a way that you don't have to make any assumptions about your patients. The other side of that is, I've studied cigarette smoking, and, it became universal to ask patients, do you smoke? And, we have to integrate drug histories and sexual histories into uniform communication so that we don't force people into making, assumptions about who their patients are, what their risks are. So I think that kind of premise has the ability to sort of say, well, I know what this kind of patient is, or that kind of patient, that all actually are obstacles to good care.
Let me ask you a question about looking at this kind of in a reverse way. There was an interesting decision made in public health in Massachusetts, which was to get the epidemiological information we needed from newborn screening on newborn HIV rates. But because of the stigma associated with it, there was a lot of protection about the privacy of information about HIV that was handled differently from information about other diseases. And that led to this morally ambiguous at best decision to screen all newborns for HIV, but not to tell the patients' families, the newborns' families, that those patients had HIV. So knowledge was sort of, and so this, there was this, and that was really a good faith effort in some ways to try to combat stigmatization and consequences of it, but also one might find themselves at risk of backing themselves into a corner like that. And I'm sure there are other dangers in reacting the wrong way to stigma.
Yeah, I think that's such an interesting question, because in a way, the dilemma you present is it would be very helpful to have this data. And so the best way to do it is to screen everyone, but we don't want to have to stigmatize people. So we won't even share the information with people for whom it could be highly relevant. And I see that as a conundrum of stigma, that if HIV wasn't so highly stigmatized and so feared, and and there are such effective treatments now that anyone would need and want to know whether they had an infection. But these are the kinds of dilemmas, in a way, that stigma builds into our systems. And so when we think about stigma as a problem for medicine and healthcare and for people who experience it, that kind of anecdote reminds me of how valuable it is to reduce these stigmas, and that societies benefit. They can collect the kind of information they really need to build public health systems. Individuals benefit because they don't have to hide the disease from family and friends. they benefit because they can proactively get treatment as opposed to resisting or being denied treatment. So all of these seem to me to be an element. And, we think stigma is bad. We teach our medical students, it's not good to stigmatize your patients, that stigma is harmful. All good, but given the dimensions of its, incredibly negative impacts on individuals and health, I would have thought we would have done better over time. And so I think that it's an issue for everyone to be thinking about and examining internal bias. And, this has been something that's been explored in recent developments in inclusion and equity, but these areas.
Let me bring in a question from Alan Wolf, one of the pediatricians here at the hospital. And I want to I'm going to add a little addendum to the question to bring it into the sort of medical context, the medical practice context. So do you think the diagnosis of COVID was stigmatized in 2020 and has been destigmatized by 2023? What are the drivers? And the addendum I want to ask is, Twitter put some doctors into a very prominent messaging capacity across American society, and some of them were shrill on this topic that you brought up in your talk, which was stigmatizing patients who had COVID, and I think particularly perhaps by the medical profession, unvaccinated patients. And there were even calls by people with prominent academic appointments in prominent institutions, calls to not treat unvaccinated patients, and things that were really pretty surprising. And so, as you think about Allan's very interesting question about whether this stigmatization has changed, I wonder also if you could think about, what does this tell us about what we need to do in medical education, to really address this issue of what I found to be a surprising and also a not surprising reaction by physicians. It's definitely a very loud reaction.
Yeah, it's a really fascinating and important question. And kind of at the end of this project, I do want to take on some of the questions that have appeared as a result of COVID. And I think there was obviously, and we know this, incredible stigma and discrimination against Asian and Pacific Islanders in our country, and watching people get beat up, or, the hostility that it elicited in the course of the pandemic reminded me of some of the most, horrifying aspects of HIV and the discrimination and antagonism that it unleashed. And we've probably never seen a epidemic that was as divisive as COVID in many ways, which in some ways is ironic because we developed relatively quickly approaches to prevention through vaccines, strategies of prevention through masks and distancing. But I watched many of these broadcasts on CNN, and the reporter would go to somebody who was in a hospital, with a severe COVID infection and say, don't you wish you had been vaccinated? Don't you regret that you were anti-vax? And I found that incredibly, destructive. And that doesn't reflect a kind of, the ethical approach that we want to teach medical students. And, there was so much heroism on the part of physicians and nurses during the pandemic, but there was also, so much victim blaming and hostility, that kind of went in many directions. And, one of the things we know from the pandemic now is just, hundreds of caregivers died. And, I think that's in ways that, we honor the risks as we should that caregivers made early in the pandemic. But in the same way, some of those caregivers were incredibly stigmatized, seen as dangerous. So it cut many ways, but I think understanding in the course of a new pandemic how these kinds of hostilities run. We do so many things that are nonsensical in public health. The airline bans, could not protect a country from COVID, but the assumptions, well, it's someplace else, it's somebody else's, somebody's going to infect me, all undermine our ability to do better from a medical and public health point of view.
We'll finish with this last question. And I think it's a very interesting one. Takes us in a slightly different direction. I wonder, and I'm quoting, I wonder how suicide fits into this discussion as the second leading cause of death among young adults and highly stigmatized, omitted from obituaries, et cetera.
Yeah, that's a great question. And it's one that I've given some thought to, but it will require much more study and understanding. But suicide is highly stigmatized in my judgment. And that creates many sort of morbidities for those who are around it. And, periodically now we do see obituaries, and obituaries have been important in my analysis because they're kind of a marker of the stigma and openness we have around different aspects of death and dying, around causes of mortality. And there is a movement that's been going on for some time about identifying a loved one who died as a result of a suicide. And there is a movement about opening up discussions about suicide and risk and depression. That is incredibly important. But I've also noticed in universities, and this would be true at Harvard as well, that very often the university doesn't want to identify a student who has died as a result of a suicide because they're afraid that it will potentially encourage related sort of social epidemiology of suicides among students. So there has always been this kind of cloaked language about, students who have died by suicide, and they're at high risk, many students today. And so part of the strategies of destigmatizing these things is knowing and understanding them, being sympathetic to them. And many families that have been affected by suicide don't discuss it. It becomes a source of secrecy and denial. And we also know that the emotional repercussions of not being able to talk about difficult things has its own related morbidities and harms. So part of my argument is that we have to introduce these, very difficult subjects and make them open and be able to discuss them, make it at ease for patients to bring their concerns about diseases that have been stigmatized to people who can help them.
Thank you so much. I'm sure that many people who've been listening have thought about their own attitudes or attitudes that they've witnessed, stigmatization that they remember from the past that they're seeing today. And again, this historical context always does bring us to the present moment in very interesting ways. And you are really the person who knows how to do that for medicine. And thank you. So we really appreciate your being here with us today. And I'm going to thank you and now share my screen and give folks a quick preview of some upcoming talks in the series.
Thanks, Ken, and thanks to everyone who came today.
Thank you, Allan. I think I'm going to share my screen. Let's try that one more time. There we go. So I hope you enjoyed today as much as I did. And upcoming talks, we have some great speakers in the coming months. Julie Gerberding, who's the former CDC director and now the CEO of the Foundation for the National Institutes of Health. Karen Copenhaver, who's the legal counsel for the Linux Foundation and has extremely important ideas about how to use open source software and licenses. Robert Langer, the most cited engineer in history. Ian Lipkin, a celebrated virus hunter at Columbia. Rick Burke, who co-founded the quite spectacular publication that comes out of the Boston Globe, Stat News. Tom Mayer, who is the medical director at the NFL Players Association and has advanced the health of American heroes dramatically in the 7 years of the health focus of the NFLPA. Molly Ann Brody, who often, if you hear about a medical or other opinion poll being quoted, so many Americans think this or that. That's Molly Ann at the Kaiser Family Foundation. We'll hear from her about the importance and strategies around how to do that. Toby Cosgrove, who's one of the best known medical hospital CEOs or health system CEOs of the last several decades, where he was at the Cleveland Clinic, and Christina Farr, who was extremely well-known health tech reporter and now a venture capitalist. And she claims that being a venture capitalist is so much like being a reporter that she really has a leg up in researching her companies and making her investment decisions. So thanking you from Chip. We'd love to hear from you. We hope you'll join us at the upcoming series. Please reach out and let us know what you think, and we'd be very pleased to hear from you. Thank you, everybody.